Good morning. Welcome everyone to Tria Health's webinar. This webinar is titled Scalable Risk, the Impact of Obesity. We will have some question and answers at the end of the presentation, so if you have any questions that come up during this time, please feel free to enter those questions into the chat box. Additionally, if you have any technical difficulties or anything during that time, please feel free to also enter those into the chat function as well. My name is Jessica Lee. I am the CEO of Tria Health, and I'm very excited today to be joined by an excellent clinical team, both outstanding pharmacists. First joining me is Jason Grace. He is our Director of Clinical Services and a PharmD here at Tria Health. And then second, we have Sarah Ochs, who's a PharmD as well. Sarah, I am very proud to say, is additionally credentialed as a certified diabetes educator, and she also holds her certification as a certified specialist in obesity and weight management. Uniquely important is that Sarah is the first pharmacist in the country to obtain that certification, and we're very proud to have her as a part of our TRIA team, and also here today to share her expertise with you about obesity and weight management. I'm going to hand it over to Sarah at this point so she can teach us a little bit more about that.
Thank you, Jessica, for that introduction, and excited to be here as well. And like Jessica said, today we are going to review obesity, what that means, common causes, why obesity is a serious issue, and solutions for improvement, starting with an obesity overview. Obesity is defined as having a higher than healthy weight for a given height, and this is measured in terms of BMI or body mass index. BMI is a screening tool, mathematical formula, resulting in a score that reflects an individual's obesity status, or more importantly, correlates with body fat mass. More simply put, the higher the BMI, the higher the estimated body fat mass or body fat percentage, meaning the higher the risk of morbidity and mortality, and ultimately higher cost to an individual, one's employer, and society. Obesity is defined as a BMI greater or equal to 30, but is further subdivided into categories, with Class 1 obesity being a BMI of 30 to 35, Class 2 obesity, BMI of 35 to 40, and Class 3 obesity or severe obesity is a BMI of 40 or higher. To give you an example patient, we will call him Bob for ease of reference. Bob is a 50-year-old man with a height of 6 feet and weight of 250 pounds. With this height and weight, Bob would have a BMI of 33.9 or about 34, classifying him as Class 1 obese. So having excess fat or being obese, why is this considered a disease? Disease is a condition that impairs normal functioning and is typically manifested by distinguishing signs and symptoms. So a disease in terms of obesity would be defined as an increase in body fat that promotes adipose or fat tissue dysfunction, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. The American Medical Association recognized obesity as a chronic disease state in 2013. Obesity is chronic and progressive, meaning this happens consistently over a long period of time. Our example patient, Bob, did not wake up yesterday weighing 200 pounds and then woke up this morning weighing 250 pounds. Many contributing factors and behaviors over a set time period led to the weight increase. A diagnosis of obesity increases the risk for 65 other health conditions, ranging from arthritis to sleep apnea to even cancer. And these are all health conditions that can be improved or even resolved with weight loss. And now that we have a better idea of what obesity is and how it is defined, let's look at some common causes of obesity. Becoming obese is so much more complicated than eating too many calories or lacking physical activities, or simply said, calories in and calories out. Even though that may be a major contributing factor, in addition to other key causes such as behavior, community environment, genetics, and diseases and drugs. Starting with behavior. Behaviors such as healthy diet patterns and regular physical activity are important for prevention of chronic diseases such as type 2 diabetes and heart disease. Balancing the number of calories consumed from foods and beverages with the number of calories the body uses for activity plays a key role in preventing excess weight gain. Some negative behaviors that can lead to obesity include stress or anxiety-induced eating and mindless snacking. Next, community environment, such as one's home, school, healthcare, and work can all influence people's daily behaviors. For example, a person may not walk to the grocery store because of a lack of sidewalks, or may not bike to work because safe bike trails are not available, preventing an opportunity for increased physical activity. Another example, what snack options are available at work or school? Chips from the school vending machine. At work, the break room is full of donuts and candy. Are fruits and vegetables easily accessible and available? Next, we have genetics. Our genes give our body instructions for responding to changes in the environment. Studies have shown different genes that may contribute to obesity by affecting our hunger or fullness. For example, ghrelin is the hungry hormone and stimulates our appetite, and leptin is the appetite-suppressing hormone that tells us when we are full. Our gut peptides regulate feeding behavior by negatively or positively influencing food intake during a meal and the time interval between meals. We all know that friend who can eat 5 Big Macs from McDonald's and not gain a pound, or the friend who thinks about 1 Big Mac and gains 5 pounds. Inherited genetic factors such as a slow metabolic rate or low rates of fat oxidation can exacerbate the susceptibility to weight gain. Most obesity results from complex interactions among multiple genes and environmental factors, or described as multifactorial obesity, that remain poorly understood and continue to be researched. Next, diseases and drugs. Some illnesses such as Cushing's disease and polycystic ovarian syndrome, or PCOS, can lead to weight gain and obesity. Even medications to treat an acute diagnosis, for example, steroids for a sinus infection, or an antidepressant for a chronic condition such as depression, can cause weight gain. Some antidepressants are more associated with weight gain more than others. I've had many patients being treated for depression who either saw an increase in weight gain or struggled with weight loss. And being able to recognize that association, we were able to discuss that observation with the patient psychiatrist, discuss alternative treatment options, but recognition of that relationship really had a significant impact and improvement with the patient's mental state and also obesity prevention. And now that we've identified some common causes of obesity, let's review the effects or consequences. Economical and societal consequences of obesity. As we said earlier, the higher the BMI, the higher the estimated body fat percentage, meaning the higher the risk of morbidity and mortality, and ultimately higher cost to an individual, one's employer, and society. Society overall bears the burden of obesity, from premature mortality, higher incidence of chronic conditions, lower health-related quality of life scores, increased disability-adjusted life year scores, and a range of other factors. One metric that can help quantify the overall burden of obesity on the medical system and society is to assess the economic costs, which can be split further into direct and indirect costs. Direct medical costs may include preventative, diagnostic, and treatment services related to obesity. For example, hospital stays, nursing homes, medications, physician visits, and lab draws. Indirect costs relate to morbidity and mortality costs, including productivity. Morbidity is the increased risk for the diagnosis or presentation of various chronic conditions associated with obesity. Looking at survival, the Prospective Studies Collaborative estimated that being overweight reduced median survival time by 1 to 2 years, class 1 obesity by 2 to 4 years, and class 3 or severe obesity by 8 to 10 years. Productivity measures include employees being absent from work for obesity-related health reasons, decreased productivity while at work, and premature death and disability. On an individual level, according to the CDC, medical costs for people with obesity is $1,420 higher, or 42% higher than those of normal weight. Why is this? The costs attributed to obesity are almost entirely a result of costs generated from treating the diseases that obesity promotes. For example, a report entitled National Health Spending by Medical Condition in 2009 showed that annual medical costs for people with diabetes total over $190 billion. Although not all of these costs are attributed to obesity, excess weight is the single greatest predictor of developing diabetes. If not for obesity, these costs would be much lower, as would costs for other conditions caused by excess weight. From 1999 to 2000 through 2017 to 2018, the prevalence of obesity increased from 30.5% to 42.4%, and the prevalence of severe obesity increased from 4.7% to 9.2%. Estimated trends show continuation in growth of obesity and severe obesity prevalence for 2030. With these growing trends, direct and indirect costs will only continue to grow as well. Let's look at other health conditions associated with obesity. Obesity has other potential health risks, including many of the chronic conditions listed here: type 2 diabetes, high cholesterol, high blood pressure, cardiovascular disease, infertility, asthma, depression, among many others. Obesity is associated with the health conditions listed here, meaning that obesity either causes or contributes to a positive diagnosis. As we discussed previously, trends suggest that the prevalence of obesity and severe obesity will only continue to increase well into 2030, meaning the related health conditions and associated costs are likely to continue to increase as well. However, overweight and obesity are modifiable risk factors, and evidence shows that weight loss leads to lower risk of many weight-related diseases, meaning that if weight gain is a major contributing factor, that weight loss shows improvement or even resolution of these health conditions. Let's look more closely at the relationship between obesity and other chronic health conditions. Why obesity may impact other conditions. What is the relationship with obesity and other health conditions? Starting with type 2 diabetes. More than 87% of adults with diabetes are overweight or obese. 87%. Excess adipose tissue or fat tissue may cause cells to change, leading to insulin resistance and ultimately diabetes. But like we said before, if weight gain is the cause, weight loss can be the solution. The American Diabetes Association and American Association of Clinical Endocrinologists recommend weight loss of 5 to 15% from baseline of initial body weight to improve both blood glucose levels and hemoglobin A1C, both objective measurements of diabetes control, and in order to reduce the number of doses or of glucose-lowering medications. The Diabetes Prevention Program demonstrated that intensive lifestyle modification focusing on weight loss reduced the rate of progression from impaired glucose tolerance to diabetes over 3 years that was more effective than metformin. Next, we have high blood pressure. An increased BMI can lead to additional strain on one's kidneys and heart muscle to supply oxygenated blood to the body. In the Nurses' Health Study, in which women were followed for up to 16 years, the fraction of new hypertension cases that attributed to overweight and obesity was 40%. The weight loss-induced decline in blood pressure generally ranges from about 0.5 to 2 millimeters of mercury for every 1 kilogram, or 2.2 pounds of weight lost, which was seen from phase 1 of the Trials of Hypertension Prevention study. Controlled blood pressure additionally reduces the risk for heart attack and stroke. Next, heart disease. Excess body weight can physically alter the structure of the cardiac musculature, leading to heart failure and lack of blood flow efficacy. Obesity is one of 5 leading modifiable risk factors that are estimated to be responsible for more than half of cardiovascular mortality. Over 90% of cardiovascular events occur in individuals with at least one risk factor. A patient is at increased risk for cardiovascular disease with a waist circumference of more than 35 inches for women and 40 inches for men, or described as an apple shape, signifying the increase in visceral fat around our vital organs. Next, relating to cancer. Gaining weight as an adult increases the risk for several cancers, even if the BMI is not reflective of overweight or obesity status. The relationship between increased weight and cancer risk is unknown, but the hypothesis is that the fat cells release hormones that affect our cell growth, possibly leading to cancer. Data from the United States cancer statistics were used to assess trends for cancer associated with obesity, which were estimated to cause 40% of all cancers in the United States in 2014, with the implication being that the burden of obesity-related cancers might be reduced through efforts to prevent and control obesity. Next, osteoarthritis. Extra weight may place extra pressure on joints and cartilage, causing accelerated deterioration. Obesity has a direct mechanical effect on weight-bearing joints and can worsen pain and functional disability. For every 1 pound of weight loss, that relieves 4 pounds of pressure on the agitated joint. Even 5% of weight loss from initial body weight has been shown to have clinically significant results and improvements in chronic health conditions. For example, our initial patient, refresher, Bob, our 50-year-old male, 6 feet tall, weighs 250 pounds with a BMI of about 34 or class 1 obese. Let's put that 5% of weight loss into more relatable terms. If we say 5% weight loss from Bob's initial body weight, that's a weight loss of 12.5 pounds. Achievable and possible with effort. Our patient, Bob, he still has a class 1 obesity designation with a BMI of 32.2, but with that 12.5 pounds of weight loss, he has improved his current health conditions and decreased his risk for further complications. More specifically put, if our patient's beginning blood pressure was 150/90, a 12.5 pound weight decrease could result in a decreased blood pressure reading of 140 or better. For osteoarthritis, 12.5 pounds of weight loss would result in 50 pounds of reduced pressure on his joints. If he had diagnoses in diabetes and cardiovascular disease, his blood sugars would be improved and his risk for complications would be decreased along with cancer risk. The link between obesity and chronic health conditions has been established. With our example patient Bob, we have seen what improvements can be made with a 5% or 12.5 pounds of weight loss from his initial body weight. But what happens when obesity and associated chronic health conditions are not controlled? Mismanagement of obesity has long-term ramifications. We have seen that positive correlations between increased BMI with increased morbidity and mortality leading to excess healthcare expenditures. With morbidity, we had seen increases in the risk of various health conditions, including diabetes, high blood pressure, high cholesterol, cancer, and many others. For mortality, a reduction of 8 to 10 years of life for patients with class 3 or severe obesity. A patient individually spends over $1,400 more on their own medical costs in addition to direct costs with respect to hospital stays, physician appointments, medication costs. The negative impact of obesity on patients' quality of life seen with lower scores in physical functioning, health perceptions, and vitality. Even social consequences, the way obese individuals experience stigma and discrimination based on their physical appearance. Metabolic syndrome is closely linked to overweight and obesity with inactivity. Metabolic syndrome is a cluster of conditions that occur together, increasing your risk of heart disease, stroke, and type 2 diabetes. Signs and symptoms of these conditions include increased blood pressure, high blood sugar, excess body fat around the waist, and abnormal cholesterol or triglyceride levels. In summary, obesity is a chronic disease that causes both physical and emotional distress, leading to preventable health conditions and preventable costs. As we said previously, if weight gain is the cause, weight loss is the solution. We reviewed clinical trials demonstrating the effectiveness of weight loss and governing medical bodies that recommend weight loss for improved disease state outcomes. So, what do we do next? This is where Tria Health comes in. I will now turn it over to Jason, our Director of Clinical Services.
Sarah, thank you so much for that information and really good background in verifying that obesity is a chronic condition, the complications associated with it, and the problems that can occur if it's not addressed. And really, that is what Tria Health specializes in, and our expertise lies in chronic condition management. It's been well described in literature that chronic conditions are a major driver of healthcare costs, and as the number of chronic conditions increase, the cost associated with managing those patients increases exponentially. Tria Health, we specialize in identifying and engaging patients with multiple chronic conditions. For most conditions, there are a variety of treatment paths available, but the primary method to meet goals of therapy and prevent complications is medication therapy. So utilizing healthcare professionals that are medication experts is an excellent strategy to achieve medication optimization. Ensuring each patient has the right drug and the right dose to achieve the desired outcomes is the focus of the Tria Health Pharmacy Advocate Program. In terms of the programs that we have available, the PA program is our primary program that we use to identify and engage patients with multiple chronic conditions, to set them up with an assigned clinical pharmacist. Our team here is residency trained, board certified diabetes educators that have spent their entire career focused on patient care and achieving outcomes with one-on-one consultations with patients. This allows us to identify medication-related problems and help patients meet their goals of therapy. We have additional programs, population-based programs that help drive medication optimization, including removing barriers such as cost with our Affordable Med program, adherence with our compliance alerts, and closing gaps in care with our clinical alerts. We also have two additional add-on programs, our weight management program that's called Choose to Lose, and our tobacco cessation program that's called Stop. In a lot of ways, these two programs are very similar in that ways to achieve goals with these types of patients, there's a couple of things that are very, very important. Identifying motivation to change and desire to change, and really focusing on the habits and behaviors that have led to either continued tobacco use or obesity. So with our Choose to Lose program, we offer patients a comprehensive program that includes a multidisciplinary approach with health coaches and dietitians, pharmacists, as well as a technology platform with the Lose It app. This is a high-touch point program that allows for individualization of a plan with a high degree of accountability with an assigned dietitian. And again, part of the program includes identifying and ensuring the patient's motivation and willingness to change, understanding that the path that has led them to their current behavior and coming up with a plan to alter that, utilizing the technology within the Lose It app, which allows you to track activity and hydration and caloric intake. But that's a key component in terms of understanding their behavior and their caloric intake, is tracking their food on a regular basis so they understand the decisions that they're making and the impact that has in terms of their caloric intake. And we have pharmacists available to, if a patient is an appropriate candidate for obesity medication, to do a comprehensive review with the patient to look at the treatment options available and make sure that we identify the best choice for that particular patient. If you look at the options available for treatment of obesity, there are a number of conditions that are contraindications for certain medications. So understanding the patient's other comorbidities and reasons why you would maybe want to avoid certain obesity medications is an important piece of that. And so we have a team available in-house to have those consultations with patients and then work with their physician to get them on an appropriate obesity medication if that is in fact needed and necessary. what we found with our weight management program, just at a very broad level, a few key findings. One is we've had much lower utilization of medications than we originally anticipated when we started offering the Choose to Lose. And we are certainly aligned with that. We agree that behavior modification and non-pharmacological strategies to achieve weight loss is the primary goal, and is the focus of our program, but there's certainly situations in which medications can play a role. We've had less than 20% of patients who have been participants who have gone the medication route to assist them in their efforts to achieve meaningful and clinically significant weight loss. We've also found that the Lose It app tracking component from both physical activity, hydration, and calories is a key component for successful weight loss and behavior modification, and also holding the patient accountable even to themselves, in addition to what the health coach is working with and the dietitians are working with them on. And from a global perspective, we've had some really good successes, not only with weight loss and pounds lost, which is obviously important, but also with patients who have been able to de-intensify their medication regimen, get off of blood pressure meds, cholesterol medications, and de-intensify their diabetes regimen due to what Sarah was alluding to earlier. 5 to 10 to 15% weight loss can result in a drastic improvement in your metabolic and diabetic parameters and allow for an adjustment and in cases discontinuations of medications, which is certainly the big goal of the program from our perspective. So with that, I'll turn it back over to Jessica Lee.
Thanks, Jason and Sarah. We really appreciate your expertise and insight regarding this topic of obesity. Just a reminder for those of you, we're going to enter into a question and answer session. So those of you who do have continued questions, please forward those questions via the chat function to the presentation organizers. We will be able to filter those in as we go along. We have been getting some questions this week, and so we'll start off with some of the questions we received earlier in the week as we continue to receive questions in over the course of the next few minutes. So, Sarah, when you were talking earlier, one of the questions that was forwarded to us is, and I'm sure we get this question, you get this question a lot, is why is BMI the measurement? I think BMI is a controversial measurement that we talk about in the disease of obesity because of factors that can change your weight that may be related to quote unquote being big boned or more muscular. So can you tell us a little bit about why that's the measurement, and then also maybe are there other alternative measurements that may be utilized in assessing obesity as a disease?
Sure, absolutely. So BMI is the most common measurement because it is cheap and it's effective. Every year when you have your annual doctor's appointment, they're going to do your height and your weight. That's just standard protocol. So based on that height and weight, your BMI can be calculated and it can be tracked on that annual basis when you have that doctor's appointment. So cheap, convenient, easy, and then again, you have that association, like you said, not that direct, actual fat mass percentage that is revealed with the BMI, but again, with the height and the weight, just with the increased BMI, you typically have that increase in the body fat percentage or that body fat mass, which is really where the issue with obesity comes into play. But you're absolutely right. Again, there are better, more effective tools than a BMI, but then that's when you start getting into specialization and where there's more cost. So for example, you can do a DEXA scan, a dual energy X-ray exophthalmometry, excuse me on that. So something that would be used as a bone scan that patients would use for osteoporosis prevention or treatment. That's something that can be used to identify fat mass. Again, obviously expensive with that. You could do a skin caliper, or it's called a pinch test, where you're measuring the skin fold thickness. There's also underwater weighing, bioelectrical impedance, where if anyone has done this, where you stand on a scale and you can hold on to almost like a metal stand, and it's measuring the electrical current that's running through your body, again, measuring that fat mass, and even it can break down the lean mass, your hydration status, what areas of your body are containing more fat, more compared to lean areas. So there are a lot of other options if there were patients that were interested in that. But again, BMI is the most convenient that we have available.
Yeah, it sounds like it's also more about trying to create some measurable goals than per se being categorically designated as a obese class 1, 2. There sounds like there's just a measurement for trends, probably,
Sure.
Correct?
Absolutely, yeah.
So tell me a little bit about this question came in, and I'm curious to hear what your thoughts are about this. It says, why is obesity considered chronic, and has it always been this way? And you alluded to that in the presentation, but what are your thoughts about the chronicity of obesity and sort of maybe even as it relates to the standard American diet, or how we sort of are culturally accustomed to a way of eating maybe that's maybe contributed somewhat to that?
Sure, and chronic, exactly like you said, like we alluded to earlier in the presentation, chronic meaning happens over a long period of time. So this is still an ongoing education area, just as far as weight gain, obesity, and again, just being declared a disease by the American Medical Association back in 2013. That wasn't that long ago that it was officially stamped that. So once that door opened, then a lot more education research has been ongoing, but still not long-term like we have with a lot of other chronic health conditions. It was really that relationship that was seen or noticed that when we see these trends of the increased BMI, that you see these other associated chronic health conditions as well. So this is new research, again, ongoing, and there's a lot more understanding as far as the fat mechanics, why patients are gaining weight, why some more than others, what genes, what is involved in this process and contributing causes. There's still the obesity stigma, where obesity was considered and still is considered a disease of laziness. You are this way because you put more food into your mouth than you should, and you are not physically active enough. So that was a big part, and again, that is a contributing factor, but there are lots of pieces to a very complicated puzzle that leads to obese, the super obese, or even those classes, something that takes a long period of time, calories, activity, and behaviors. So it's really that multifactorial puzzle that brings all of that together to make it a chronic disease state. And the standard American diet, that is that is just another big piece to the puzzle right there. When you have fast foods, the high saturated fats, just greasy fried foods, those are things that are at your fingertips when we are on an on-the-go society that is working very hard and trying to make things as quick as we can. And those are the options that are most readily available to us. So these are all things that are being evaluated and are in the process of change, which is good that we're heading in that direction.
So Sarah, you know, obviously I feel like my perception is that there's not a one size fits all perspective to this. There's a lot of individualization that goes on. If you have all of those potential contributing factors to why people may have obesity, can you tell me a little bit about what you believe is effective when you approach a patient or an individual who has obesity in terms of getting started?
Sure. So as far as getting started and just things that have proven effective, just through, again, clinical studies and research, there are components that that have been shown to be proven effective and have those results to back them, just with the weight loss and weight maintenance. So diet is one part, having that caloric deficit, physical activity, recommendations of 150 moderate active minutes per week. And then also the behavior, being able to identify and trigger what are the behaviors that are contributing to this. Why are we binge eating? When are the times that you eat? And being able to have that Lose It app and being able to have that food journal to track those trends can help you identify those behaviors and really work on undoing those. But got to that point, or even the scale, the weighing and monitoring your weight each week. These are all things that have proven successful as far as contributing to the long-term goal of losing that weight and getting off medications if possible, and decreasing or eliminating those chronic health conditions associated as well. So those are all components that we have in the Choose to Lose program, which I think is great and individualized, like you said. So starting a patient, just getting a background in the history as far as where are you at currently, as far as health conditions, what medications are you on, how are you feeling generally, mood and emotional status. I mean, those are all things that can be improved with weight loss and going through this journey also. What are things that you have tried in the past? What was successful for you? What did you like? What didn't you like? What does your day-to-day routine look like? If you work 80 hours a week, trying to find an hour a day to go to the gym, that's just not realistic. So really getting to understand the patient on a personal level. What are your personal goals? What is your motivation for doing this? Is it, I have grandkids and I want to be around a long time for them? I had a patient who his motivation was, he is a type 2 diabetic and he was borderline A1C being above 10%, where that is the point where insulin would be added on. And he had, his mother was a type 2 diabetic. She was insulin dependent. She had lost a leg due to diabetes, and he saw a very painful road, just as far as her relationship with diabetes and obesity. And he did not want to go down that road. She passed away, and he did not want that for his life. No one would want that. So he turned 40 years old, and we worked out a plan as far as working on his diet, working on his exercise routine. And he was busy working and had kids just like all of us, but really focused on that motivation of not getting on insulin. That was a big one for him. And also, what are some activities that you enjoy? That as far as getting your heart rate up, it doesn't have to be an hour a day, even doing 10-minute intervals and times that are convenient for your schedule. And this particular patient, he's very fun to work with. One of his favorite things was Pokemon Go, a game that I was not familiar with, but something that you can do on your phone and chase down characters. That was something he enjoyed doing with his kids. So not only was that a bonding activity for him and his family, it's something that was realistic, it fit with his schedule, and it was fun. So he enjoyed doing it, making that a motivation for him that it's sustainable for the long term. He's not going to a spin class or to a yoga class or something that might be more appropriate for someone else who's interested in those sort of activities. This was what did it for him. So ultimately, after working through his medications, again, getting this plan in place, he was able to get his A1C down to 6.4, which is amazing. He had lost 15 pounds, so he was still in that obese category, but just like our example patient, Bob, it was, I believe, 6% of his weight loss, 15 pounds, and he was at the pre-diabetes stage. His A1C was that well controlled, and he was in the process of decreasing the doses for his medications, and he was motivated to continue that weight loss journey, and then hopefully even get off of his medications at some point. So it's very specialized for each individual person. Like you said, there is no one size fits all, and that's one of the things that's so tricky with obesity and weight loss. Everyone has their own motivation, everyone has their own story, everyone has their own schedule. So being able to talk that through with each patient really is beneficial and can really make a difference, not only for their weight, but also for their health as well.
Well, that's a good example of not only success, but like truly how you have to individually figure out the plan for each person. That's an awesome story.
Yeah.
So let's talk a little bit about, Jason, you were mentioning in the Choose to Lose program some conversation about medications. This question says, do most clinicians recommend using medications to treat obesity, and aren't medications related to weight loss harmful?
Part one, I mean, there's the potential for side effects with any medication, and that's no different when you look at our main treatment options available for obesity. So those are things that have to be considered. What are the most common side effects? Would that be a specific problem with that patient and the other medications that they're taking? So there is some complexity in choosing the right option and the safest option for somebody when it comes to the obesity medication. So that's has to be considered. The first part of the question, we have found that a lot of physicians don't routinely prescribe obesity medications because there's a general belief that they are not covered on the health plan. And knowing the cost associated with a lot of these is can oftentimes be a barrier that prevents physicians from prescribing them. They're usually not opposed to it, but I think when it comes to high blood pressure, high cholesterol, metabolic syndrome, or obesity, the first line treatment option is always going to be non-pharmacological and diet and exercise. It's unfortunately, a lot of times that is not enough, and other treatments are needed and necessary. And so within our Choose to Lose, I mean, this is the one program we have the most experience with, and within that program, all of the obesity medications are covered on the plan design. And usually if we are recommending a medication and we're communicating and calling and talking to the physicians, they are more than willing and wanting to prescribe these medications. They oftentimes are unaware that they were available at an affordable copay rate for the members. And so when they are aware of that, they are certainly willing to prescribe it when it's clinically appropriate.
So we're getting a lot of questions about wanting some more detail regarding the Choose to Lose program. So Jason, one of the questions is related to how the pharmacists are the coaches and pharmacists assigned one-on-one, or do you get somebody new each time?
Right.
And then how do we approach? Is it an inbound? Like, do people elect to be in the program?
Gotcha.
Can you talk a little bit about like selection into the program, how you get assigned, and then what that ongoing monitoring looks like? And then you also mentioned some incentives or some help to the medications too. Right. I just asked you 5 questions.
Right. So we'll try to knock them off as many as we can here with a single answer. But it is an opt-in program. We don't do any specific targeting or outreach to members who might be candidates for our Choose to Lose program. Rather, it is driven through the employer who promotes the program internally and lets their employees know that this option is available to them. And then they can contact us directly. We have a multitude of different ways in which you can sign up for any of the TRIA programs, whether that be through our website or through calling into our customer service team. As long as they meet some minimum criteria for participation, which is usually based upon their BMI and their other comorbid conditions, they are assigned a specific dietitian that will do their initial intake and initial consultation to understand the patient and understand where they're at, and set up their initial SMART goals that have to do with hydration, caloric intake, and physical activity. If the member desires or the dietitian feels like it is appropriate, then they will be referred to a pharmacist for a discussion about medications. We have found that oftentimes members or patients want to be aware of what obesity treatment options are available to them, but aren't necessarily interested in starting on a medication immediately. They just want to know what those options are, and down the road, if I don't have success after 3 to 6 months, that might be where we end up. All patients, at least within our program, are assigned a single dietitian who does all of the intense follow-ups between telephonic consultations and messaging through our Lose It app, which is a great platform that allows for easy and efficient communication between patient and their dietitian through the messaging app associated within the Lose It platform. And so there are weekly communication, whether it be through the Lose It app or through telephonic follow-ups with the dietitian to ensure that the patient is meeting their goals, tracking their weight. We have a Wi-Fi scale that is sent to patients that allows us to accurately track their weights because it syncs in with the Lose It app. But yes, they are always working with an individual dietitian and a specific pharmacist that would do the initial kind of medication review and then follow up specific on that medication if they do end up initiating something. And then a lot of communication and phone calls to physician's office if medication is needed and necessary. And we always have good, like I said, mentioned earlier, good results and success whenever we pick up the phone, call a physician, tell them that their patient is enrolled in a weight management program, they have coverage available to them for weight loss medication, and based upon their other medications and conditions, this would be the best option for them. We haven't had any resistance to that at this point. In an effort to drive some degree of engagement and also provide, remove a potential cost barrier associated with the medications, groups we've worked with do incentivize coverage for those obesity medications and reducing the copay if they're in the Tria Health Choose to Lose program. So if it's set at a certain copay level, there may be a 50% reduction for those members that are included in the Choose to Lose program. I think I knocked off most of those, but there might be a couple more.
So, and that hit a couple of questions. So obviously you're hitting the creating of a relationship between the pharmacist, the health coach and the member. So there's some connectivity one-on-one there.
Absolutely.
And you mentioned, I think there was a question that came in regarding the partnering with physicians. And so you alluded that obviously the physicians who are involved in the care of these individuals is looped in.
Right.
Okay.
Yes, absolutely.
You actually hit another question too related to cost and interaction. So maybe when you talk about you've told the physicians, but what about interactions? Do you work with physicians and patients if there's potential drug-drug interactions with their medications?
Oh, absolutely. Whether that be obesity medication or like any patient we have within our pharmacy advocate program, if there's a drug-drug interaction that requires a change in therapy, we are going to pick up the phone, call the physician, and walk through options that are available, especially if it's going to impact or decrease the effectiveness of one of their needed and necessary chronic medications.
Great. We're getting some questions about like target employer groups for the Choose to Lose program. So I'll just kind of add to Jason's. Right now, the Choose to Lose program is offered as an add-on to the Tria Pharmacy Advocate program. So obviously adding into an additional layer of the chronic condition management program we have, we generally target membership of 500 and more in the members in terms of the size of the employer. And are obviously using, you already really mentioned, Jason, using a lot of motivational and behavioral components to not only the election to be in the Choose to Lose program, but also into our STOP program. Right. And then also sort of combines well with the Pharmacy Advocate program because we're working with these people who have chronic conditions in addition to potentially some obesity problems as well.
Right.
We are running out of time. I'll have one more question that I will ask you, Jason, and this has to do with a conversation regarding getting off medications. And we've kind of talked a little bit about this, but this is coming in from a person who's sort of asking, I have type 2 diabetes. I have 3 medications. My friend has type 2 diabetes, but doesn't have any medications. How's that possible?
Mm-hmm. Right.
Sort of that difficult comparison thing. Right. And maybe you can just allude to and I know Sarah talked a little bit about it, what are the possibilities with weight loss at even a small component or amount? And maybe Sarah can speak to that too.
Well, and certainly, Sarah, if you want to chime in here after I am done, feel free. I think all of the I know all the clinicians here at Tria, we all consider weight loss is it's essentially one of the prescriptions available for treatment of type 2 diabetes. If you look at, I've got the diagnosis, how am I going to treat this? We all know, maybe we don't know, all know, metformin is where we kind of start, and then there's a host of different medication classes that may get incorporated in based upon their blood sugars and their A1C. But weight loss should be considered right along with metformin is a first-line treatment option. And we find that patients are oftentimes that is not explained to them or described to them that significant, that 5 to 10 to 15% loss of body mass will result in as much A1C reduction as any of these medications that we tend to tack on. And so if you need a 0.5 or 1% loss in A1C, absolutely losing 10% of body weight is one method that could potentially get us there. And so we have a lot of success with patients in we call it medication de-intensification, but getting them off of medications if they're on 2 or 3. And to the point that you were describing earlier, I mean, for type 2 diabetes, you have patients who might be on 4 to 6 medications and some that have it managed with diet and exercise. And there can be some gaps in knowledge for patients of even recognizing that because I carry this diagnosis does not mean that I'm going to be on medications or multiple medications for the rest of my life. There is a potential for managing this without medications, even if you're somewhat 2 or 3 years into the diagnosis and you are under the impression that, well, I guess I'm on a medication the rest of my life. There's a possibility that we can halt the need for additional meds or even go the other way and get off with significant and sustained weight loss. Sarah, I don't know if you have anything to tack on to the end of that.
Yeah, and just agreeing and supporting what you're saying, exactly that when patients are given a diagnosis of diabetes, it's like they're given a lifetime sentence that I will have this for the rest of my life, that they're not told that it's reversible, or even just learning more and really focusing on the education. How do carbohydrates affect your blood sugars, how weight loss can contribute to getting off of these medications, that it is not a lifetime you will be on these for the rest of your life, that there are options and ways that the patient can contribute to really bringing down those blood sugars, that A1C, and getting off medication, and really harping on that education and making the patient a advocate for their own health. And then also, in addition to what you said, I have several patients who also control their diabetes with just diet and exercise, and they are able to do that successfully as well.
Right.
Gosh, that sounds like a lot of cost savings, bottom line, one patient at a time. So right. Thank you, Sarah, and thank you, Jason, for your expertise today. Just a reminder, the Choose to Lose program is an add-on program to the Tria Health Pharmacy Advocacy Program. We target our services to employer groups who have 500 members or more. And the Choose to Lose program is priced at a per engaged member pricing model. And we encourage any of you who are having further questions regarding the Choose to Lose program or Tria Health's Pharmacy Advocate program to please contact us either through our website or any of our presentation moderators. They'll be happy to get with you to give you more information. We hope you found the information regarding obesity helpful today, and we wish you well and hope you have a happy rest of the Tuesday. Thank you.